Yeah, okay. Thank you so much. So, first and foremost, I would like to thank the Association of Physicians of Orissa for inviting me for this wonderful symposium. I think the first talk, was excellent. I think, in fact, listening to that, it has made my job easy. So, I will not be touching the anatomy and the physiological aspects of it. Will be directly going to the clinical aspects of thyroid nodule. So what we're going to do is we're going to discuss the therapeutic approach to, or the diagnostic approach to thyroid nodule. And as sir rightly said, all thyroid nodules are not malignant, and we need to have a standardized approach to diagnosing and following these patients. So I'm going to give you a standard approach. I think that is something which everyone can follow, and I think it will make things much more simpler in future. Okay, so first let me start with some very key points which we should all understand before we understand the topic of thyroid nodule. Sorry. Yeah. So first and foremost, we need to understand that all thyroid nodules are not malignant. This is something which our patients need to understand, and also a lot of doctors need to understand, because a lot of the time, a lot of panic is being created behind something, as they say, much ado about nothing. A lot of the time most of the time you have a benign nodule and you're just, worried, sick about something which is not very important at all. Another important thing which we need again to understand, that all thyroid nodules need not be operated. We have seen a lot of patients unnecessarily being subjected to surgeries for thyroid nodules which should have been just left behind on their own. Another common thing I often observe is use of thyroid cintigraphy, thyroid scan, commonly for any thyroid nodule. Now, thyroid cintigraphy is indicated only in selected cases of thyroid nodule. We'll see where they are indicated in our due course of presentation. So you don't need to do a thyroid scan or order a thyroid cintigraphy or a technetium scan or radioiodine scan in all patients with thyroid nodule. And another important thing is thyroglobulin is not a tumor marker in a patient with intact thyroid gland. So again, I've often seen patient with an intact thyroid tissue being asked to get a thyroglobulin done. Remember, thyroglobulin is very useful for follow-up of patients, especially post-thyroidectomy, but it's not very useful for patient from the diagnostic point of view. So please don't order a thyroglobulin when the patient has an intact thyroid tissue. Most importantly, ultrasound is a very important test for evaluation of all thyroid nodules. And again, if you have any radiologist friend listening to this, please report them in a standardized format, in a TIRADS or a ATA risk score format. These are all available, I think, and if you report it in a standard manner, I think the clinical approach to that also will automatically become more standardized. Okay, so let's start with what exactly is a thyroid nodule. So a thyroid nodule is a discrete lesion in the thyroid gland which is radiologically distinct from the surrounding tissue. So there's a distinct lesion. We'll see some photographs of it. We'll do a lot of visual learning in this as well, and I'll show you some photographs so you'll get an idea of how thyroid nodule really looks in an ultrasound. And in fact, one thing I often encourage all my fellow colleagues, physicians, ENT surgeons, everyone, that do look at the plate which is given by the radiologist also. That's very useful. That's a very learning, a visual learning from that is very, very significant. And when you start then collaborating with the FNSC reports, and you will become an expert if you keep seeing more plates instead of just seeing the reports given by the radiologist. Okay, so as sir rightly said in the beginning, how common are thyroid nodules? Well, in India, 9.6% of the population by ultrasound would have a thyroid nodule. So if I keep doing an ultrasound on everybody, you will find 10% of the population having a thyroid nodule. Clinically, by palpation, you will find it in about 1 to 2% of patients. This is the data from India. And of this, only 5% of thyroid nodules are truly malignant. So that number is very small. So out of 100 people who are evaluated to have a thyroid nodule, only 5 of them will have a malignancy. And in endocrinology, we often say we are blessed, because even the cancer that we deal with, that is a thyroid cancer, even if you deal with a papillary thyroid cancer, most of the time the prognosis of these cancers are also very good if they are diagnosed at the right time. So again, it's important to be prudent and pick up the right patient for right diagnosis and right treatment. But I think 95% of the patients are not going to have anything major. Which patients tend to have more likely to have malignancy? Children. So again, younger age group, you are more likely to have malignancy. So if you find a thyroid nodule in a young child, it's always better to subject them to an FNSC. Men, for people men are more likely to have malignancy. Age extremes of age, so generally more than 60 years of age, you will find more likelihood of malignancy, and younger age group again more likelihood of malignancy. If you have a history of head and neck irradiation, again commonly done for CA, for the oropharyngeal cancers, which are very common in India. At least in my part of the country, you find a lot of patients with carcinoma of tongue, carcinoma because of the use of oral tobacco. It's a very common problem in our part of the area, and I think that's we find often patients post-operatively given head and neck irradiation, and then if they have a thyroid nodule, that needs an evaluation. And again, if you have a family history of thyroid cancer, all these patients require a more intense evaluation. Now, is history and physical examination accurate for evaluation of thyroid nodule? Now, we all love history. We have a lot of teachers in this group, a lot of professors, but the fact is that often thyroid nodules on a clinical examination may be misleading. So it has low sensitivity and specificity for a prediction of a thyroid malignancy. So I think don't just rely on clinical examination, and I think further evaluation, at least an ultrasound, is mandated in all these patients. So just a clinical examination may not be enough. However, if you do a clinical examination, what points would suggest more likelihood of malignancy? So as said, rapid growth of the nodule. If you have a rapid history of a rapidly growing nodule, if you have a history of head and neck irradiation, patient receiving total body irradiation after a bone marrow transplant, family history of thyroid cancers like MEN2, Cowden syndrome, and so on. If you have this history, you should really be having looking out for it. And on clinical examination, if you have a hard fixed mass, if you have a vocal cord paralysis, if you have cervical lymphadenopathy, or if you have obstructive symptoms, and generally, how do these patients generally complain? If they have a larger nodule, when they lie back, right, they often feel cough, they often have, coughing sensation, they often, on lying down, and they often feel dyspneic sometimes on lying down, and such kind of symptoms, you should really, orthopnea as they say, right, so they should be really looking at these symptoms, and in these cases, you should consider more close evaluation of these patients. Now, which are the patients, which group of patients have a higher risk of malignancy? Is it those patients who have non-palpable nodule or those who have palpable nodule? Now, the risk of malignancy is the same. So, whether you have detected the nodule by clinical examination or you have detected the nodule by ultrasound incidentally, in both the cases, the risk of malignancy is equal. So, do not just depend again on whether it's palpable, not palpable, and so on and so forth. So, now let's look at the stepwise algorithm for evaluation of a thyroid nodule. So I'll give you a clinical step-by-step process which you should follow. So first important step is to get a thyroid function test done, a TSH done, and this is where the role of thyroid Cintigraphy really comes into picture. Now if you have a TSH which is either normal or high, then immediately send the patient for an ultrasound. So directly you can send the patient for an ultrasound. However, if you have a TSH which is low, in those cases you need to do a thyroid Cintigraphy or a thyroid scan. Again, in thyroid scan, you might find hot nodules, you might find cold nodules, or you might find something known as a warm nodule. We'll discuss that in the subsequent slide. But if you find a hot nodule, generally, and if the patient has symptoms of thyrotoxicosis, you can consider sending the patient for radioactive iodine therapy. But if you find a cold nodule, that is very important because sometimes cold nodules tend to be more likely to have malignancy. So if you find a cold nodule in a thyroid Cintigraphy, again you need to send the patient for an ultrasound, and such patients should always undergo an FNSE because the risk of malignancy is slightly higher compared to a general, a thyroid nodule, right? So again, is there a relation between the TSH level and the risk of thyroid cancer? Yes. So when you have a higher TSH, the risk of thyroid cancer is higher, the risk of malignancy is higher. So higher the TSH, more the likelihood that the patient could have an underlying malignancy. Now let's look at the ultrasound. So let's say you have a patient who comes to you, you did a TSH was slightly higher, let's say patient has subclinical hypothyroid, TSH is around 6 and 7. What do you do next? You send the patient for an ultrasound. Remember, ultrasound is an operator dependent process. So two things you have to do. One, train your radiologist or talk to your radiologist to report the thyroid ultrasound in a more standardized manner. This takes a lot of time, it takes a lot of communication, so this has to be done. Secondly, always ask the plates to be given and always look at the ultrasound picture, ultrasound plates, and always cross verify with what the findings have been written by the radiologist. If you have any doubt, always discuss with the radiologist. So it's a simple ultrasound, but it requires a lot of communication, and I think a good communication is very useful in this scenario. Now, what American Thyroid Association has done is that they have standardized the criteria to based on the ultrasound picture, and they have classified that as patients having high risk of malignancy, intermediate, moderate, low risk, or very low risk of malignancy. So what are the cases where you are more likely to have malignancy? That is the risk of malignancy close to 70%. So very importantly, you should, if you have a hypoechoic nodule, in such cases the risk of malignancy is higher. So as I told you, I'll show you some pictures. So here, this picture you can see, this is a nodule, right, which I've shown, and this is the normal thyroid tissue, right? So the surrounding tissue is normal thyroid. Now you need to compare the echogenicity of the nodule with the surrounding tissue. Now this is actually a cystic lesion, so there's a complex cyst, but what I'm trying to say is that the echogenicity here is lower than that of the surrounding tissue. So whenever you have a hypoechoic nodule, you should always have your, again, the risk is higher. Sometimes, radiologists report that as echogenic, right? I think that's a wrong word to use. They should either report that as a hyperechoic, isoechoic, or hypoechoic, and that is something very important. Again, microcalcification, so you can see here, small dots calcifications. Again, these calcifications generally suggest possibility of papillary thyroid carcinoma. Again, they are more likely to suggest a malignancy. If you have an incomplete halo is basically the surrounding tissue, right? So surrounding tissue which surrounds the nodule. And if you have this halo which is incomplete, you can see here perhaps, yeah, this is the picture where you have an incomplete halo. You have see some tissue coming out of this halo. Again, this is more likely to be malignant. If you have a invasion of the local lymph nodes, so if you have lymph node extension, lymph node involvement, or extrathyroidal extension, or irregular margins of the nodule, all these things suggest a higher possibility of malignancy. And very importantly, remember, if it's taller compared to wider, right? So if it's like this, right? So the nodule is like this, right? It is taller like this compared to wider like this, then the risk of malignancy is higher. So taller nodules tend to have more risk of malignancy. So all these cases, the risk of malignancy is higher. Now, what about intermediate suspicion? So intermediate suspicion is when you have hypoechoic nodule with solid with a regular margin. So if you have a hypoechoic, so again, this is a good picture to show you a hypoechoic nodule. So you can see the echogenicity here is less compared to the surrounding tissue. So whenever you have hypoechoic nodule like this, risk of malignancy is generally higher. So if you have hypoechoic nodule but regular margin, that would suggest an intermediate risk. Hypoechoic nodule with irregular margin would suggest a high risk, right? So that is something you have to keep in mind. Again, you can see a very nice picture of hypoechoic thyroid nodule, and these patients, generally the risk of malignancy is slightly higher. Which cases have low risk? So this is a typical case where you have a isoechoic or hyperechoic nodule. So you can see here the nodule, you have a very nicely seen nodule, which is, it is regular in shape, and the echogenicity is very comparable to the surrounding tissue. It is isoechoic, slightly hyperechoic. So this is more likely, very reassuring picture. This is more likely to be a benign nodule, and the risk of malignancy is low. So these are the cases where you really have low risk. And which are the cases where generally you have very low risk of malignancy? Cystic nodule. You can see here this is a complete cyst. So you can see just dark black tissue here. This kind of black tissue is generally suggestive of a cyst, and this cysts are generally benign, right? And again, you have something like this. You have a complex cyst here. You have, heterogeneous cyst. Again, you have, again a partially cystic nodule. All these things, generally suggest a low risk of malignancy. So this is the ATA classification, right? So there is a website for this. This is ATA calculator. So you can, again, if you are able to identify the pattern in a thyroid nodule, you can yourself go to the website and calculate the ATA risk. And there are points which are given, and this categorization is done in based of TR1, TR2, TR3, TR4, and TR5, right? And depending on the TR status, so that is TREDS 1, TREDS 2, 3, 4, and 5. If it is TREDS 1, it is benign, so you don't need to send the patient for an FNSE. If it's TRED 2, again, risk of malignancy is very low, so generally you don't indicate, FNSE is not indicated. TREDS 3, you consider an FNSE if it is generally more than 2 centimeters in size, 2.5 centimeter. TREDS 4, if it is more than 1 centimeter, definitely 1.5 centimeter, definitely consider malignancy. And if they have very high risk features, then you should consider FNSE in almost all cases with this high TRED score. So again, next step would be FNSE. So in selected patients with thyroid nodule, so especially when you have higher TRED score, and generally speaking broadly, so if you don't remember the exact value, you can always see, generally when you have a thyroid nodule more than 1 centimeter with high risk features, you should consider doing an FNAC. That's a simple rule of thumb that I've practiced, right? Generally to avoid missing out. Sometimes, the exact length measurements may not be available or may not be very well done by the radiologist. So again, whenever I find any suspicious feature and the nodule is more than 1 centimeter in size, I generally subject the patient for an FNAC. You don't need to do a core needle biopsy. In fact, FNAC should be done, right? FNAC is a priority, and a core needle biopsy is not indicated, nor is a excision biopsy not indicated in all patients. FNAC must be done in selected patients where the further evaluation is required. Again, if you have high risk nodules, like I said, more than 1 centimeter, you can consider doing an FNAC. If it's low risk or very low risk, 1.5 2 centimeter would be the indication. If you are dealing with a purely cystic nodule, like we saw earlier, such type of cystic nodules can be just left behind and FNAC is not required. Right? Now, what happens if you find an FNAC and the FNAC is benign? Then what do you do? Right? This is a common scenario. So 95% of cases you will find that you subject the patient for an FNAC, but FNAC is benign. So how do you follow up this patient? So if FNAC was not indicated in first place, you just follow up with ultrasound if necessary. If you have high suspicion, then you repeat ask the patient to come back after 6 to 12 months. Now, generally what I do is I repeat the ultrasound before I repeat the FNAC, right? So in most of these cases, we generally first repeat the ultrasound. If you find any new characteristics, you can consider repeating the FNAC. Again, if it's intermediate or low risk patient, right, you can repeat the ultrasound after 1 year or 2 years. Very low risk, again, after 2 years, and generally less than 1 centimeter, very low suspicion, not even required to repeat the ultrasound in future. Okay, so let's say we have done the FNAC. How do you interpret the results? So just like, a radiologist should report the value in terms of DIRAD score, a good pathologist would, or a histopathologist would generally report these in what is known as a Bethesda classification. So Bethesda classification is very important. So again, communication becomes easier when you use the same terminology. So Bethesda classification is used to classify the patient based on the FNAC characteristics. So you have Bethesda 1, 2, 3, 4, 5 and 6. Right? So you have Bethesda 1 where it is non-diagnostic. We'll discuss each of them. Bethesda 2 is when you have a benign characteristic. Bethesda 3 when you have something known as atypical or atypical nodule, atypia with undetermined significance, or follicular lesion with undetermined significance. Then you have Bethesda 4 which is a follicular neoplasm. Then you have Bethesda 5 which is suspicious for malignancy, and Bethesda 6 which is confirmed, almost likely to be malignancy. So these are various Bethesda classifications. We'll discuss each of them in detail. So when you have Bethesda 1 where you have a non-diagnostic FNAC, so FNAC report the histopathologist cannot make any conclusion. In such cases, it's generally advised to repeat the FNAC. It's always a good idea to repeat the FNAC. If the patient is very apprehension, it's a low risk nodule, you can follow up after 3 months or 4 months. But generally what I do is at the right time again repeat the FNAC. It's always a good idea to repeat it. And in cases where you have very highly suspicious feature, then I directly send the patient to a surgeon to do a diagnostic lobectomy. But most of the time again the idea is to repeat the FNAC. Again, if you have a Bethesda 2, right, which is a benign reported lesion, we generally again follow up this patient with an ultrasound. So like I said, 95% of the patient you will find a benign lesion, and in all these patients we already discussed, we will generally follow up with a repeat ultrasound, generally done after somewhere between 6 months to 2 years. That is the usual rate depending on the clinical status that you see initially. If you have 2 or more FNACs which are benign, right, so you have done one FNAC benign, second FNAC benign, then no further follow up is required for that nodule. But remember, sometimes patients can have multiple nodules and you have done FNAC from one nodule, but the other nodule is silently growing behind it. Then it is very important to evaluate the other nodule also. So every nodule ideally should have a close examination and evaluation. But if you find that you have a single nodule and that single nodule repeated FNAC is benign, then you can leave the patient and you need not worry about it in future. What about Bethesda 3 and 4? So Bethesda 3 and 4 is where you have this indeterminate pathology. So you have something known as FLUS or AUS, or you have something known as follicular adenoma. So you have follicular cells which are seen. But remember, an adenoma, follicular adenoma and follicular carcinoma cannot be differentiated based on a histopathology, based on an FNAC. So that's the clinical challenge. So that is one of the cases where you have a difficulty in making a confirmed diagnosis. Now in the West you have something known as molecular markers which are done, but in India they are not readily available. So molecular markers can be considered if you have those available. Molecular markers generally tend to have tend to rule out a lesion. So they will say for sure that this is very less likely to have malignancy, but they cannot rule in a lesion. So the likelihood, they'll rule out a possibility. So they'll say with more surety that this is not malignant, but they cannot say with very high surety that it is malignant. So that is one of the challenges with molecular markers. So in India, what we generally do is when you have such lesions, we do a diagnostic lobectomy, right? So if you have Bethesda 3 or 4, we generally subject this patient to a diagnostic lobectomy, and then that gives you a more confirmed picture. What if you have Bethesda 5, that is suspicious of malignancy? In such cases, you discuss with the patient. Again, if you have molecular markers available, you can consider doing that. But in most cases here, we generally do either of these. We either directly send the patient for a thyroidectomy, or we do a diagnostic lobectomy. So when you have Bethesda 5, you need to start, talking to your surgeon. Generally, we send this patient to head and neck oncosurgeons. So start the process of dialogue with the surgeon, send the patient to visit the surgeon. It would be a good idea in these cases to start that dialogue, because this patient would eventually more or less require surgery. And when you have, of course, Bethesda 6, which is confirmed malignancy, you send the patient for surgery. So this is the approach, general approach based on the Bethesda. Now, what is AUS and FLUS? So AUS is basically, or ACUS is atypical cells of undetermined significance, and FLUS is follicular lesions of undetermined significance. Sometimes you have these lesions present. You have sometimes Hurtle cells which have been reported. Again, sometimes the problem with Hurtle cell is that Hurtle cell could be completely benign, but it could suggest a Hurtle cell malignancy also. So again, that is one of the challenges. So sometimes if the radiologist does see a Hurtle cell or a follicular cell with undetermined significance, that is what they reported in their histopathological picture. Now, sometimes you have, very rarely, you have a condition which is known as medullary thyroid carcinoma. Medullary thyroid carcinoma is a very rare thyroid malignancy, but it has very poor prognosis compared to other malignancies. So, one of the diagnostic tests which is done, one of the biomarker is calcitonin, right? So calcitonin is a useful marker for diagnosis of medullary thyroid carcinoma. So one of the questions which is a debate is, should you consider measuring calcitonin in all of your patients who come with thyroid nodule? Now, answer is, it is very controversial, and American Thyroid Association neither recommends nor suggest against it. Now, if you have a patient with a strong family history of medullary thyroid carcinoma, 100% you should do calcitonin. But if there is no such family history, no family history of thyroid cancer, or the patient is not knowing, there is no clear history, in that cases, the clinical decision has to be made by the clinician. In our practice, we do not measure calcitonin in all the patients unless you have certain features where you are thinking. And one hint I'll tell you from my experience, we see a lot of patients. So I work in a center where you have a very high center of excellence for carcinoma, for cancer, and we work very closely with them. So we see a lot of patients with thyroid cancer in our practice. In my practice, what we observed is that if you have an FNSE report which is FLUS or FUS, in such cases there could be a medullary thyroid carcinoma. We had cases like this where the radiologist has reported that as a follicular cell, but sometimes turns out to be medullary thyroid carcinoma. So in such cases, again, you have Bethesda 3 or 4 or Bethesda 5, it would be a good idea to consider measuring the calcitonin also. However, always remember that calcitonin can have a lot of false positive, and sometimes in certain cases you might have to do, you might have to do a pentagastrin or a calcium stimulation test. We generally don't do it in routine practice because most of the time we subject this patient to surgery whenever you have any suspicion. But this is something you can consider doing if you have these facilities available. Okay, now let's look at the role of thyroid Cintigraphy, that is a thyroid scan. We already discussed briefly earlier where you should consider doing a thyroid scan. So thyroid scan should be done whenever you have a patient with low TSH. So the TSH is low, you should consider doing a thyroid scan. Why this is important is because when you have a low TSH, you could very well have a hot nodule. When you do an ultrasound, they'll report that as a hot nodule. They'll report that as a nodule because in an ultrasound, they'll not be able to see whether it's a hot or cold nodule. And secondly, you could have a hidden cold nodule behind it, and that cold nodule, the risk of malignancy is higher, right? So whenever you have low TSH on a baseline evaluation, these are the patients you should consider doing a thyroid scan. You can do either a technetium thyroid scan or radioactive iodine thyroid scan, depending on whatever facilities available. I'll come to this in a minute, why both the things have importance in their own light. So you need to then select this patient, whether the patient should be subjected to further evaluation, that is an FNSE or not, depending on the thyroid scan report. Now, one thing you have to remember is that the hot nodules, the risk of malignancy is very low, right? I'm not saying it is 0%, but the risk of malignancy in hot nodule is less than 0.1%. Hence, whenever you have a hot nodule, generally you can follow up these patients without necessarily considering doing an FNSE. But you always remember that when you have a hot nodule, the risk of malignancy is generally lower. Now, there is something which is known as a discordant nodule. So this is where, this is what the point I was trying to make. So sometimes what you have, you do a thyroid per-techneted scan and do a iodine scan. You find a discordant value in that, right? So most thyroid nodules generally will show congruence. But in 5% of malignant nodules, they appear hot in a per-techneted, but appear cold in an iodine scan, right? So this is what is known as a discordant scan. And discordant scan generally can be malignant. So this is where, if you do a thyroid scan and if you are reported as a hot nodule in per-techneted scan, it is generally it should be confirmed with a radioiodine scan, right? So this is something you should keep in mind. So sometimes you have a discordant scan. I think this is something endocrinologists also need to understand, very importantly. So we often subject the patient for a per-techneted scan. We find a hot nodule, we leave it behind. What we generally do is, when you find a hot nodule on a thyroid scan, on a per-techneted thyroid scan or technetium-99 per-techneted scan, we generally send the patient for possibility of a radioactive iodine ablation. So I again send the patient back. Again, my nuclear medicine friend does a radioiodine scan. If there is a discordant nodule, we directly again counsel the patient and subject the patient for an FNSE. But if you have a concordant nodule, we directly subject the patient to a radioactive iodine therapy, right? So again, it's RAIT is very useful in hot nodules. So again, it's a definitive therapy. So again, if you find a hot nodule on a per-techneted, always send the patient back to the nuclear medicine physician, and then you can deal with that in that way. So does an autonomous or a nodule which is hot, are they malignant? Like I said, if you have a hot nodule on a radioactive iodine scan, generally they are not malignant. The risk of malignancy is very low. It is less than 0.1%. So generally, again, you need not worry too much about hot nodules. What are warm nodules? So warm nodules is a distinct entity. They are nodules that have uptake same as the surrounding tissues. So they are neither hot nor cold, and they must be distinguished from hot nodule by something which is known as T4 suppression test. We'll not go into too much detail of this, but if anyone you find something which is reported as a warm nodule, either send the patient to an endocrinologist, or you can possibly consider doing an FNSE and ultrasound, a USG guided FNSE in those cases. So if you're not very sure, again, warm nodules, the risk of malignancy in warm nodules is higher compared to what is reported as a hot nodule. So again, that is something you should keep in mind. Okay, now finally, the topic which is we often see, we are very likely to see more commonly also in future, is what is known as a thyroid incidentaloma. Now, thyroid incidentaloma, what is an incidentaloma? It means that it is accidentally detected. So you go for some other test, but you find that the radiologist reports a thyroid nodule. It is very, very common. Again, like I said, I work in a high volume cancer hospital which is attached to our hospital. So we find a lot of the times ultrasound is done for some other reason. So somebody finds a lymph node, somebody finds something else, and they do a neck ultrasound, and again neck ultrasound, the radiologist incidentally reports that as a thyroid nodule. Another case, PET scan. So patient goes for a PET scan for something else, and then the PET scan, they report a thyroid nodule or a thyroid tissue uptake, which is again something known as thyroid incidentaloma. Now, when you do a PET scan and if you find an incidental lesions, the risk of malignancy is very high, right? So again, FDG PET, and if there is an incidental lesion, you should always consider subjecting the patient for further evaluation. At least an FNSE is a must. FNSE must be done in these patients if you find these lesions in PET scan. But something you should always remember, a focal uptake on a PET scan. So if you do a FDG PET and you find a focal uptake, and especially if it's more than 1 centimeter, this patient definitely should be sent for FNSE, because the risk of malignancy is very high in these cases. However, if you find a diffuse uptake on a PET scan could suggest a thyroiditis, right? So sometimes you find a diffuse uptake, and if you find a diffuse uptake in that case, what I typically do is after a few weeks we do a thyroid per-techneted scan in such patients and look for evidence of thyroiditis. And also thyroid function test must be done in all these patients. But if you find a diffuse uptake, generally it is more likely to suggest thyroiditis rather than malignancy. So if you find a focal uptake, again, it's a very good idea to communicate with a nuclear medicine physician. See, thyroid nodule is a subject where talking to your radiologist, to your histopathologist, and to your nuclear medicine physician, communication is very important, and to your surgeon also. Communication is very important, and the more you communicate, the better you learn, the better your patient is served. So this is an area where teamwork and communication is very, very important. So again, whenever I find an uptake, whenever an uptake has been reported, I call my nuclear medicine physician and I talk to him whether it's a focal uptake, whether it's a diffuse uptake. If it's a focal uptake, I definitely send this patient for an ultrasound and USG guided FNAC. Right. So just to summarize some important take home messages. First is, remember, clinical features are not very reliable, so don't just rely on a clinical acumen. Ultrasound should be done whenever you suspect or whenever you see a thyroid nodule. At least an ultrasound with a good radiologist is a must. You don't need to do a CT scan, you don't need to do an MRI, you don't need to do a PET scan. You just need a good ultrasound. And an ultrasound classification must always be reported based on a TIRADS or a ATA classification. Remember, a hypoechoic nodule, which is it's taller than wider with irregular margins. These cases, the risk of malignancy is higher. Third important point, selected cases of thyroid nodule must undergo FNAC. So all patients don't require FNAC, but generally speaking, when you have a thyroid nodule with suspicious features more than 1 centimeter, these patients should be definitely subjected for an FNAC. Remember, it's FNAC, not a core-needle biopsy, not diagnostic lobectomy. The first step is FNAC. So FNAC must be done, and FNAC must be reported as Bethesda scoring, because Bethesda scoring, it's like I said, it's a common form of communication between the endocrinologist, physician, radiologist, histopathologist, the surgeon. Everybody, understands Bethesda score, and hence it should always be reported by the histopathologist in a proper format. Thyroid Cintigraphy or a thyroid scan is indicated only in those patients where you have TSH which is low, and mainly what we are trying to see is whether you have a warm or cold nodule, because these are more likely to be malignant. And finally, localized incidentally detected thyroid nodules on a PET scan definitely must undergo an FNAC, because they are more likely to suggest malignancy. Why I am telling you this? Because I see this very commonly. A lot of times PET scan is done. PET scan is very commonly done nowadays, by a lot of people, right? And you often find thyroid uptake in the thyroid PET, and then ultimately the patient is subjected and sent to us for evaluation, and this is something you should be very well aware about. So I thank you for a patient listening. Like we said in the beginning, we have made an app which is called Notes in Endocrinology. You can visit our website. It is endocrinology.co.in. This app is available on the Android as well as the iOS Play Store. So these are the those who use QR codes. You can directly click this photo and download this app. It's free of cost. This topic in great detail and other topics in thyroid and adrenal, pituitary, diabetes, all these are there on this, and we are constantly updating this, so it will be very useful for physicians all over. So I thank you, and I thank